There's yet another compound, alectinib, govadin. Do you want to comment briefly on that?
I think they all have, you have this succeeding generation of these newer and newer compounds. To me, every other drug seems to be like the previous drug, and making it works in crizotinib-resistant patients, penetrates the CNS, and has a fairly tolerable profile. So I think we're going to have a big challenge in the coming years as to how to sequence these agents and how to do them.
Whether they'll all get approved. I mean,
and whether they even
do we
get
need
approved.
10 ALK inhibitors?
So whether, but I also think that genomically this may be a less complex tumor than we see this, unlike even EGFR tumors. I'm just speculating here completely. That my hope is, if you're going to cure an advanced non-small cell lung cancer patient, is this the first population we can do this in a CML model?
I hesitate to use the word cure.
No, I know, but I think this the amount of I think our patients, the big message is the ALK positive patients have not one but multiple options coming down the pike, and I don't have anything specific to add about alectinib.
It's only 3 to 8% of the population, but these patients live twice, 3 times as long, so the prevalence is actually a bit higher. We're talking 8, 10, 12% of our patients in clinic.
Yeah, so I'd like to get Alice and Ross's perspective on this, and this is about the CNS metastasis in the ALK positive population. Kind of understanding that came out of the crizotinib experience. Let's face it, crizotinib was initially started as a MET inhibitor and kind of got off the ALK exit and got approved. But we never thought it was a potent ALK inhibitor. Now we have this second generation, which are really ALK design. And the whole CNS thing, do we know that it's a pharmacokinetic advantage, or is it just that whatever gets there is such a much more potent ALK inhibitor that's really the real reason why it seems to have better activity in that? I don't know if we have PK studies on CSF, but we know that it's, or do we?
So we do know that crizotinib does have poor penetration into the brain. There's been one case report by Dan Costa where he looked at the CSF levels of a patient of his who was on crizotinib and relapsed in the CNS, and found that the level in the CSF was about 0.03 of that in the plasma. So we know that, but to be fair, we have seen some responses of crizotinib in the brain, but clearly it's a weak point. And I do think a lot of the failures that we see in the CNS represent pharmacokinetic failure rather than true resistance.
And so what do we know about the PK of drugs like alectinib and ceritinib with regard to CSF penetration?
Ross, any data there?
So it's mostly animal data, but I think it's good that people are actually starting to think this is relevant data to generate. So certainly more gets in, it's maybe about 10 or 15%, but as you point out, every bit that gets in is actually doing more potent, so it probably gets it both ways.
And there are certain new ALK inhibitors that really do have very good penetration, like even higher than that. Alectinib I've heard is even higher than that, and there's a new Pfizer third-generation drug, PF6463922, that's really been engineered to really get into the CNS at high levels.
So you foresee a time where we may end up sequencing patients not through just 2, but possibly 3 or more ALK inhibitors?
We already do that now.
Before we resort to cytotoxic chemotherapy.
Yeah, because pemetrexed is pretty good therapy when you get to it.
Our backup measure.
Yeah.
So what you've described, Alice and Ross, it really becomes very perplexing. How do we figure out the optimal sequence of these inhibitors, particularly with crizotinib, still first line? Will these second generation inhibitors displace crizotinib? We've described the toxicity, but even though ceritinib may be looked at first line, I worry that the toxicity, particularly the GI toxicity, may potentially inhibit its development. You mentioned some of the strategies with dose reduction, but I know you've also looked at changing the time of day or adding small snacks. Can you bring that up?
So
briefly?
for ceritinib, it does seem that food ameliorates a lot of the nausea and vomiting. However, really, the label does specify that ceritinib should be given on an empty stomach because that's how all the trials were done. Now, there has been one normal healthy volunteer study where they looked at ceritinib and food and showed that food does increase absorption. So there's a post-marketing study that will be done looking at the effect of food on ceritinib. But for some patients, really, one of the ways that we can manage nausea is to sneak in a little bit of a meal. I'm not supposed to, but
so
patients find that incredibly helpful. Mm-hmm. So I do that, especially when we have to dose reduce down to 450, for example. I know the absorption will be boosted by giving them a little bit of food with that.
And there's been no manifestation of prolonged QT intervals or any other side effects with the
No, I haven't.
higher absorption?
No.